from Switzerland, and I have been working with metastatic cancer patients for several decades now, and in particular with metastatic prostate cancer for about 18 years. I've learned a bit, and over the last decade, the landscape has changed a lot for patients with metastatic prostate cancer. While before 2003, we had nothing to offer to those patients, short of chemotherapy, which was not prolonging life, and in many cases made life miserable for those patients. But since 2003, many new drugs have come onto the market, some of which have been shown to prolong life with much less side effects than the initial chemotherapy. For the next 45 minutes, I'd like to show you what those new developments are, and I'd like to compare those conventional new treatment options with our own protocol that we have devised and refined over the years for patients with metastatic prostate cancer. When you look at the survival curves for those men in the left side here, where my cursor goes up and down, the survival in percent, and here the years, then you see clearly that stage 1 and stage 2 disease has a very good prognosis. 5-year survival for those men is higher than 80% today. But it looks quite different, this story, once metastatic disease is there. Then the 5-year survival is usually below 10%. Some statistics say 3%. Now for those men, the situation is better today than 15 years ago, but still not satisfying. Some facts for prostate cancer. Still today, about 20% of all men who are diagnosed will be diagnosed in an advanced stage, meaning they come to the doctor with bone pain, lower back pain that doesn't go away. Turns out to be metastatic pain from prostate cancer. 20% of all men that are diagnosed or who are diagnosed with prostate cancer come at in an advanced stage of the disease. 50% of all patients, that's also something important, advance to metastatic disease even after curative treatment has been done, meaning after radical prostatectomy, after radiation treatments, they still advance towards metastatic disease. So were they selected wrongly for curative treatments? Or did they have metastatic cells in their blood circulation when they were treated with radical prostatectomy or with radiation? We don't know. But the number of those who progress after curative treatments is still very, very high. 100% of all patients with advanced prostate cancer will receive at some point in time so-called hormone therapy, or better, hormone ablation therapy, meaning drugs that drive the testosterone of those men down to almost 0 levels, castrating them chemically. What is important to know that all of those patients who receive hormonal ablation therapy will develop invariably a castration-resistant disease stage, meaning that they have 0 or almost 0 level of testosterone, but still their disease progresses, called castration-resistant, was formerly called hormone-refractory disease. Now for those men, the therapeutic options are very, very limited, even today. If you look at what has happened in those last 15 years with metastatic and hormone refractory, today called castration-resistant prostate cancer, then this slide will show you what we are able to do for those men today. We still can try hormone ablation when metastatic prostate cancer comes to the office, or a patient with metastatic prostate cancer comes to the office. We can use one of those new drugs called abiraterone and enzalutamide. We can use new immune therapeutic approaches with ciprofloxacin and Prostvac. These are two vaccines that I will introduce to you later. We have newer and better chemotherapy protocols that I will show you a bit. We have a bone protection program that we can use for patients with bone metastatic disease. And we have a protocol since about 18 years, we are practicing this, that we would call complementary or holistic or integrative oncology protocol for metastatic prostate cancer patients, where we use phytotherapy, means plant-derived treatment methods, where we use antioxidation, and where we use detoxification. Now, this slide shows you the usual treatment sequence for somebody who comes with metastatic castration-resistant prostate cancer. This is what we can offer today. Taxotere or docetaxel is the chemotherapy. Ciprofloxacin and Prostvac is the immunotherapy. Abiraterone, Zytiga also called, and enzalutamide, Xtandi is the trade name. These are two new hormonal treatments that we can do, even in patients that have so-called castration-resistant disease. There is a new chemotherapy drug out that's a relative of docetaxel or Taxotere called cabazitaxel. And there is a new treatment out since 2 years that is a radiation from the inside with radium-223. Now, in the next couple of minutes, I will discuss each of those possibilities for patients with metastatic prostate cancer in a little bit more detail. First, we look at docetaxel. Taxotere has improved the treatment for those patients over the formerly used metoxantrone. This was also a chemotherapeutic drug that had merely some meaning for symptom relief, meaning pain, but did not prolong life. Then the first Taxotere study came out showing that if used properly every 3 weeks for patients with this condition, it could prolong life by a very small amount, but significantly by 2.5 months in the medium. They cost around 500 to 600 pounds per month for this treatment, including those medications that are usually needed to calm down the side effects, nausea and vomiting. Nowadays, about a year ago, or almost a year ago, there was a big study published where Taxotere and hormonal ablation treatment were used initially for patients with metastatic disease, and could be shown when you do that very early on that this combination is well tolerated and it has a much better effect on life prolongation. And you see that here. Those men who start with both methods together, meaning chemotherapy with Taxotere plus hormone ablation therapy, they have an advantage that is not 2.5 months, but that is over a year to almost 2 years. So that's something for men who are freshly diagnosed with metastatic prostate cancer to consider. We look at ciprofloxacin and Prostvac, two quite different approaches. Both come as a tumor vaccine. Prostvac is not registered and approved yet, but in phase 3 study, but ciprofloxacin is already approved. It's called Provenge. Here you see a couple of details for this treatment method. What is it about? The doctor is taking some blood from the patient with metastatic prostate cancer. This blood will be used to isolate so-called dendritic cells. These are cells in our immune system that are needed to present antigen to our cellular defense system. Now, the company that makes that happen is called Dendrion, and they are putting those DC cells for a couple of days into a culture. That means in the laboratory, they create many, many millions of those cells that later on will be used for treatment for the patient. Now, 3 to 4 days later, the culture is ready and will be given to the patient as a tumor vaccination. Now, that method is approved by the FDA in the US and has been offered to patients during the last 4 years. Here you see the survival curve with the use of cipuloid cell compared to the placebo. And you see there's a slight improvement of about 4.1 months for those men that receive this treatment. The treatment is, however, extremely expensive. It's about 65,000 pounds for 3 treatments per year. Nevertheless, Medicare in the US is paying for that treatment. The other vaccine that I want to introduce, because the phase 3 study results are already better than cipuloid cell, is called Prostvac. Now here, the principle is a bit different. You don't take blood from the patient. You use a antigen that is given as a cancer vaccine to the patient. And the antigen is composed of a PSA molecule and 3 cofactors, not so important. As a vector, you use a virus that is not damaging the human body, that's not dangerous for a human, and you are giving that vaccine via this virus to infect the whole body cells. Now, in the normal cells, that virus is not going to replicate. In the cancer cells, it can replicate and can show some of the antigen on the outside of cancer cells, and your immune system, or the immune system of the patient, now can recognize those cancer cells. In the end, the data showed that the Prostvac curve of survival looked much better than the cipuloid cell in phase 3. So here, we are not talking about 4 months survival benefit, but we are talking about 8.5 months survival benefit. And if they manage to keep the cost lower here, because it's not so individualized, we don't need blood from the patient that goes to the lab and is being cultured and comes back, we can just use the vaccine. I hope that this vaccine treatment is much cheaper than the cipuloid cell. Then we have a chance to add time for those patients without a big side effect. Now we look at abiraterone. This has been hailed when it came out. It was developed in your country. Here it has been hailed as the breakthrough for patients with metastatic and hormone refractory or castration-resistant disease. Now, it is a steroid compound that inhibits one enzyme. It's not that important, but the effect is that even those cells that can still make testosterone are inhibited, and testosterone levels really drop to 0. It's manufactured by Johnson & Johnson. The overall survival benefit is about 4 months. The cost, however, is extremely high, over 3,500 per month, but I think it's paid also in your country by your NHS system. Now, we used abiraterone a lot at the beginning in the hope this would be the key, but often the effect was possible only with a myriad of unpleasant side effects. That's why prednisone, a glucocorticoid, is often given with it, 10 milligram a day. And in our experience, the 4.2 months average survival benefit was not always so obvious for us. So we had many patients that progressed on abiraterone, and that's why we were waiting for that second drug that came out and is now available, called enzalutamide, or trade name Xtandi. And that drug has a bit milder side effect profile. Although the overall survival benefit is also rather low, it's in the range of 4 months as well, but cost again rather high. But when you now add abiraterone and enzalutamide later, which is still in some patients effective, you are able to already get 6 months or 8 months survival benefit. So there is some time gain, which is what we are after. But I read that recently your country, the NHS, has limited the access of patients to this drug, meaning it doesn't pay anymore for it, and the patient would have to come up with this enormous price tag per month. Now, cabazitaxel we can kind of treat very short here or very briefly here, because it's basically the same with a little bit more side effects than docetaxel, but let's look at that. The costs are rather high, up to 6,000 per month. The benefit that we get from this chemotherapy drug, about 2.4 months. But again, after enzalutamide is not working anymore, or abiraterone is not working anymore, and you had chemotherapy already, you can use that drug and you still can expect a response and still can expect a time gain for you. But cabazitaxel has a myriad of side effects that we know from other heavy chemotherapy drugs, and not many men continue. They do 1 or 2 treatments and then they say, I have had it and don't want it anymore. The last one that I want to introduce is the radium, or Xofigo is the trade name. That is a radioactive isotope that's injected into the vein. It circulates in the blood and then settles down in the bone, just there where bone metastases are. Not only does it help most of the patients with regard to reduction of bone pain from metastases, but it also has a slight survival benefit for those men, which we have not seen really with other drugs of that sort, like strontium, like rhenium, like samarium. Radium is the first one that is actually licensed and registered for that purpose, bone disease in metastatic prostate cancer. The cost is around 6,000 to 7,000 per month. Now, despite improvements that have been made with all these drugs, the result overall is still rather dissatisfying. If you look at these facts that I took from what's called meta-analysis, looking at many research papers, metastatic prostate cancer patients without bone metastases, 1 year survival around 80%, 5-year survival 55%. When you have bone metastases, the wisdom of the research says 1 year survival less than half, 5-year survival only 3%. This is what we know from the textbooks, that far spread bony metastases don't allow survival of 5 years. That's what old wisdom says. Metastatic prostate cancer with a lot of skeletal metastases, a lot of involvement in the bone, the 5-year survival is less than 1%. Now, I will show you that we can be better than that. And the answer to that question is, can we do better, is clearly yes. We have ample of evidence to show that. This is how we think doctors should do for patients with metastatic prostate cancer. They should use leading-edge conventional therapies that I just introduced. But they should also look at dietary interventions, physical exercise programs, psycho-oncological therapy for those patients. They should look at antioxidation, anti-inflammatory treatment, and they should look at immune modulatory treatment, besides those expensive vaccines. They should also look at detoxifying those patients. And last but not least, they should read up on specific phytotherapy protocols that we advocate for now almost 15 years and see the benefit that they could get for their patients. All with the goal to buy time, to turn this dreadful disease into a chronic problem for the patient. Long-term cancer control, improving quality of life, and prolong life in a meaningful way. That is what this combination, this integrative approach, both sides treated equally important, is all about. Now I want to show you a couple of things to our protocol addition. First, we want to talk about a little bit about dietary intervention and detox treatments. Now, here I want to start with saying that a very famous guy from the US, University of Chicago, Professor Epstein, is saying for almost 30 years that 80 to 90% of all cancers are caused by environmental factors, by wrong lifestyle choices, by bad nutrition. And allow me for 1 minute or 55 seconds to show you his video. This is Professor Epstein and his opinion.
It's important to recognize the fact that 1 in every 2 men get cancer in their lifetimes, and 1 in every 3 women get cancer in their lifetimes, and that we are facing a major and unparalleled cancer epidemic. And at the rate at which we're going, it'll become an almost universal problem in which 1 in every man will get cancer in their lifetime, unless we come to grips with this question of reducing avoidable exposures to carcinogens in the totality of our environment.
And that is what we personally probably have the biggest problem with, because we cannot really change our environment, but we can take the right lifestyle choices. And those are not smoking, not heavily drinking, no recreational drugs, trying to cope with stress, don't allow permanent negative stress on your system or on your body. Choose the wrong nutrition and you are foolish to believe that your cancer will go away. Choose the right nutrition. Although there is no real cancer diet out there, but we know what's good for us, and it's not the McDonald's every day, that's for sure. I believe a very simple program that you could look at, that is not changing too much, is outlined here. Important, I believe, is daily hydration with at least 2 liters of good, best ionized water with a very high pH. I believe that reduction of animal fats, instead, however, more fresh vegetables and fruits is important. I believe that caloric intake reduction is important. Keep your weight at the normal body weight. I believe that from time to time intravenous chelation should be done to reduce heavy metal concentrations in our system. I believe also that cyclic detoxification therapy with a special zeolite is a way to reduce environmental carcinogenic material in our body. And that particular zeolite I will show you a bit closer. We have been invited to develop a substance together with Switzerland's ETH, which is like MIT in Switzerland, the Technology Institute. And we used the zeolite and combined it with a green tea extract that this ETH Institute has patented in Switzerland. We ground this zeolite down, this volcanic stone down to micro or even nanoparticles to increase the surface. And what we saw is that this activated zeolite, which is an amorphous substance usually, out of a sudden that mineral starts to develop biological activity. And what we developed is this package with 30 sachets of zeolite green tea extract, and tested in the clinic. It resulted in the ability of removing heavy metals like lead, cadmium, mercury by oral intake. It removes even aflatoxin. That's a very highly carcinogenic substance that develops when you put meat on the grill or sausages on the grill and eat those. It removes strontium and cesium. Matter of fact, zeolite was the substance that was poured on Chernobyl when that reactor blew up, and also the latest reactor accident in Japan used a lot of zeolite to contain radiation from those isotopes. We also saw that this otherwise amorphous substance, that stone, can activate lymphatic and immune system cells. It stimulates B cells, T cells, NK cells. So we are using this substance on a cyclic basis 3 times a year for 2 months with our cancer patients to hopefully get out what is not useful and what is not advantageous in the body with regard to toxins. Now, next we want to look at phytotherapy and antioxidative compounds that we are using in our protocol. For prostate cancer patients that are metastasized, we use Imupros, which is called an orthomolecular preparation because it has a lot of vitamins, minerals, vital substances in the, we hope, right composition for our patients. It has these components in it, and they're all packaged in small envelopes so that they are released at certain times in the intestinal tract so that they cannot influence each other chemically. That was done by a Dutch company. They have the patent on that time release mechanism. We are using this compound at a dose of 1 to 2 tablets a day for prevention and 3 to 4 or 2 to 4 tablets for treatment. Our phytotherapy protocol has the following substances, 3 groups actually: prostosol, curcumin, indole-3-carbinol, artemisinin, convolvulus armensis, and imusan, and then the last 3 down here are Aeskulap cytosterol mix, MCP, which is modified citrospectin, and Biobran. Now, not all patients get all these 9 compounds. Depending on their clinical status, depending on their progression, disease progression or not, we are choosing out of those 9, and usually patients get 3 to 4 of these substances in their protocol. Prostosol is actually the one that has the longest history, and I want to talk about it a little bit. That is a herbal concoction that unites 9 medicinal herb extracts, combines those with linum life, which is flaxseed oil lignans, and with biocurcumin. And that biocurcumin is better than the normal curcumin because it really is easily absorbable, and it has been shown that same amount of this curcumin extract gets 7 to 8 times higher blood levels of the important curcuminoids that we need for prostate cancer patients. What we have seen that this prostosol is also efficacious in patients who have castration-resistant disease, and that was the main reason for us to use it. Here's what we found in the research It inhibits cancer growth dose dependent. That means when we give more, we expect more result. It downregulates the androgen receptor, that's a receptor at the prostate cancer cells that responds to testosterone or androgens in the blood of the patient and stimulates usually tumor growth. So it downregulates that receptor and thereby it has effect on the cancer growth. And what we also saw is that cells that are exposed to prostacyclin get more sensitive to radiation. So we give all of our patients who go to radiation treatment, either for their prostate disease, for their prostate cancer, or for bone metastases, we give them prostacyclin to make that radiation treatment more effective. Curcumin is another major compound that we use, and here you see what it does for prostate cancer patients, but also for other cancer patients. It inhibits cancerogenesis and it inhibits cancer growth. We found over 1,700 publications in peer-reviewed journals in the medical library. Curcumin has also anti-inflammatory effects, and it has, last but not least, also effects on angiogenesis. This is the development of new small blood vessels supporting cancer growth. So curcumin cuts those small blood vessel developments down and inhibits that, and thereby does starve metastases and the original tumor. If you look at indole 3-carbinol, that's a substance that we use for prostate cancer patients and for breast cancer patients because of its effect on the molecular level and because of its effect on the estrogenic side of the body. Now, it reduces a particular estrogen in the body, which is called hydroxyestrogen, and thereby positively influences prostate cancer, breast cancer, and endometrial cancer. There's something that many of you are already familiar. Men and women have both sex hormones in their body. Men, more testosterone than estrogen. Women, more estrogen and progesterone than testosterone. But when we age, this kind of balance is being disturbed often. And in men, when they age, the estrogenic side creeps up and testosterone goes down. All elderly men like myself, being 67, notice that. In women, the testosterone side comes up when they age. So we think that that imbalance of those two systems is creating or at least facilitating the development of breast and of prostate cancer. And our treatment is aimed to bring that balance somehow back. So with indole 3-carbinol, we can achieve that in men and in women. It increases the turnover of estradiol to estrol, which is a weaker estrogen, and thereby it inhibits breast cancer growth and prostate cancer growth. We skip this, but I want to tell you one thing that I think is very important. Indole 3-carbinol also works for breast cancer and for prostate cancer that has become hormone insensitive. That's an important fact. That's why we give that very, very benign substance, which you can get in many green vegetables, for example, in broccoli, in cauliflower, in Brussels sprouts. Here are all the vegetables where you find enormous amounts of it. But better to get the active ingredient, DIM, which is a metabolite of indole 3-carbinol, from a capsule, because you could not eat 3 kilo of broccoli a day to get the amount that you would need to get the effect. Artemisinin, we have looked at quite for some time now, and we have seen that it has similar good effects on carcinogenesis and cancer growth like curcumin. And I will not go into details with this, but you may know that this is recommended by the WHO for treatment of treatment-resistant malaria. That is the same substance. Now, last but not least, we want to look at BioBran and our own dendritic cell vaccine in our protocol. BioBran is a substance that's around for 20-some years. I've used it in the US when I worked there over a decade with good success for cancer patients. And what it does is it stimulates the cellular immune defense. And foremost within that, one particular cell type called natural killer cells that are important as first line of defense against cancer cells. Here you see the increase in natural killer cell activity over time when given BioBran 2 gram to patients with metastatic prostate cancer. This is a small sample, but it's an old slide. In the meantime, we have done this over and over again and seen that it very consistently happens that NK cell activity, means number and their function, increases with the use of this compound, which is absolutely non-toxic. I personally take, when I fly, I take 6 or 7 sachets. I fly often to Asia, 12-hour flight with many people coughing into the cabin air. So I want to be getting off that plane without any infections. So I think there is a good database out that shows that it inhibits infection, it inhibits parasitic disease, it inhibits cancer, because it stimulates the very cell that can attack all these pathogenic agents. Here is a summary of the research work on 205 cancer patients of stage 3 and 4. They all were getting 2 years of survival. They were checking, the study was checking their 2-year survival. They were all getting 2 to 3 grams of BioBran per day. And you see that the BioBran group here had a 54% survival after 2 years, and the control group, placebo group, had only about 33 survival, showing that not only in prostate cancer where we use it, but in other cancers, it can actually prolong life, and that without side effects for those patients. This slide shows you quickly our own vaccination program, which is aimed at the same cells, the metastatic prostate cancer cells. We are taking blood from a patient with either leukapheresis or simple blood draw. We are isolating monocytes. Then we try in the laboratory to create a DC vaccine. We isolate the DC cells, mature the DC cells, and then we also prime the DC cells, and that is the priming site. Priming means we show those cells in the laboratory how their enemy looks like. We present them with cancer antigen, and that schools them, and when they are given back to the patient, they may run around in the patient's body and find those cancer cells that they have been trained to find out or find, and then they can start the immune response against those cancer cells. Our program has one advantage, and we are very proud of that. We are working together with Harvard Medical School on that. We can also address immune response against so-called tumor stem cells. These are the cells that our treatment often cannot get. And they are the cells that create regrowth of the cancer. We have a special priming polypeptide cocktail that is only found in cancer stem cells. And we are training those cells also to attack tumor stem cells. Now, we are doing this now since 2 years, and there's about 30 patients enrolled in that protocol, and we see a much better response than with ciprofloxacin for those patients at a much less cost. This program costs, when it's administered in Germany and Switzerland, costs around 25,000 for 6 euro, that is 28,000 Swiss franc, for 6 treatments over a year, spread out over a year. Now I know that I don't have too much more time, but I was told that we have a 15-minute break afterwards, and if you don't mind, I'll take 5 minutes of that break to finish my talk. What can we now do with all that information? The conventional treatments on one side, our treatment on the other side, they should not be considered as enemies. They should be considered as two sides of a coin, as two weapons in the fight against that cancer. And I will show you what we have achieved by showing you one patient example that I think is very, very positive. 19 years ago, a now friend, at that time, 55-year-old patient, a businessman from Venezuela, came to me after he was at Sloan Kettering Institute in New York, where he was told, "Sir, get your things in order, you may have 2 to 3 months to live." He had a metastatic prostate cancer. His PSA at the beginning was 87.4 nanogram. He started out like everybody else with bone, or many people with bone pain. Then biopsy was done. It was positive for prostate cancer. The bone scan was done. It was positive for bone metastases. And he started on this treatment that is offered standard of care, hormone ablation therapy. 18 months run, he got out of this, and then the disease became hormonal refractory or castration resistant. And by that time, his PSA went up to 2,800, a very high number when you consider that normal is about 0 to 4 nanogram per cc. He had bad bone pain at the time and an extremely pronounced tumor anemia, because the bone marrow where blood is being made has been replaced step by step through metastases. Now, this man didn't want any chemotherapy because there was, at the time when he was in that situation, there was no survival benefit. It was only pain relief. And he said, "I don't want chemo, I take the painkiller until I die." When he came in 1998, this is when he started our protocol. At that time, it was not a real protocol. We had a couple of substances that we tried out, which later on developed into that protocol. But he started on a prostazole precursor. He took curcumin. He started on Biobran that was available. It was called MGN3 in the US at the time. And he took an imopros precursor and indole 3-carbinol. From 2003, we added DC vaccination protocol, not the one that we are using now, but a precursor of this one, and we did regular detoxification with him as well. Now, here is his bone scan when he started in 1997. You see all these black spots here and here, and in the totality of the spine, in the pelvis, are all bone metastases. He had uncountable metastases, even in the skull. You see here these black spots in the skull are also metastatic lesions. The PSA, when he started our protocol, was close to 3,000, and you see within the first year, he came down dramatically with his PSA. The bone scan taken about 2 years under treatment looked very much better. There was no visible signs of metastases in the spine, but there was still some rib cage lesions, and there might have been still some skull lesions here. But he had no symptoms anymore, no pain, he was mobile, he could do his business. Now, I saw him on 9th September, because he comes regularly to me for choline PET-CT to see is there any progression. That's a special diagnostic tool that uses CT scanning and positron emission tomography. This is what PET is standing for. And he still has now, after I don't know how many years, 17 years that is, a PSA of 0.26. He has no visible bone lesions, they're all gone. That is the green PET result of 9th of September when I saw him in Zurich. No pain, no anemia, and patient is mobile, active, and has excellent quality of life. Of course, that's not every patient that will respond like this, but I want to show you that we have plenty of patients that respond like this. Here are our clinical studies. The first one was done as a prospective study. That means we are choosing the patients that can be enrolled. In 2000 it was a very short study, only 6 months, because we wanted to see what do those substances do. And we tested a prostazole precursor substance. It was done and sponsored by the University of Kentucky, where I was working at the time. And the main results were showing that 11 out of those 15 or 16 men, 15 men, showed a response, although on the PSA, with PSA reduction, although they were considered hormonal refractory or castration resistant. Metastatic pain went down and the quality of life went up. There was only slightly side effects, sensitive breast nipples, libido went down in 25% of the patients. Later on we measured testosterone and saw that about a third of the patients that get this substance show a testosterone decrease. So their libido goes down, but 70% don't. The second study was done in 2004, sponsored by Aeskulap Clinic, our own clinic at the time. This was a study over 12 months, and 174 patients were enrolled here. And we saw the same, tumor volume down, PSA down, in more than 50% of the men that got this medication or that protocol. And the last study we did with a private sponsor. So the Aeskulap International patient couple was giving us money for that study. Was done by an independent institute, biostatistician institute. And here were almost 500 men were enrolled. And they were followed up over the last 10 years. That was the minimum follow-up period. We saw basically the same. But what came out in that study was also very important, that we have, among those who responded, we had an incredible, for us, incredible high amount of patients that outlived all the prognostic information from their physicians. Namely, you have massive bone metastases and you have another metastasis in your lung. You will not survive next year, but they survived more than 10 years by now. And this was not 1 or 2 like the one I showed you. This was a number that is surprising, namely 28 patients among the 388 survivors of those 494 patients outlived or lived for more than 10 years with double or single metastases to the bone or bone and lung. And that was a very good finding for us. We are very proud of this, and we hope that this can even be increased during the next 5 to 10 years on the protocol. Taken all together, and that's my last slide, I show you the best standard of care today, meaning this curve, the blue one, allows a survival with metastatic prostate cancer that follows about that curve. You see that at 24 months, about 30% of the patients still survive. If you now put cross-track to that, that's the red curve, you get already at 24 months close to 60% survivors. If we combine both sides, conventional and our treatment protocol, then you get about this curve. And you can see that we are here at close to 70% survival at 2 months. And that's what our research in the past 15 years showed us, that about 2/3 of the patient have a long-term survival and have a long-term control of their prostate cancer. I really thank you for your attention. I hope you can take some info from that home and inform your friends, your doctors, other patients that this protocol is out there. And if you or your friends and patients want to have contact with us, here are the email addresses and the telephone numbers for us directly in Switzerland, but also from the UK. You can easily contact the Really Healthy Company under the phone number down here, and they will help you along to get in touch with us. Thank you so much for your attention, and have a great weekend. Stay healthy and be successful in the fight against cancer. Thank you.